The word dysfluency refers to an individual's lack of fluency in their preferred language. Dysfluency has two types: specific disruptive errors and a general lack of fluency. In the first, the person is generally understandable but makes errors in their language. Not errors associated with education level, like using the word ain't or a misuse of grammar. In the second, the person's language is so distorted that the ability to communicate on a functional level is severely compromised. Some words used to describe forms of dysfluency include neologism, echolalia, clanging, or perseveration. Both hearing people and deaf people can be dysfluent. Psychiatric reasons or neurological reasons are the causes of dysfluency within the hearing population. That is, dysfluency in the hearing population is due to organic brain dysfunction. However, in the deaf population, it is not uncommon for deaf people to be dysfluent, that is, not fluent in their preferred or their best language, which could be either English or American Sign Language, for other reasons that are associated with their exposure to language as infants and children, and the use of their preferred language in educational environments. Sometimes these people are referred to as minimally language skilled. Deaf people who are dysfluent propose a unique challenge for service providers and interpreters. However, with interpreters in clinical service settings, there's an additional concern. Interpreters, because of the nature of their work, seek to understand and convey meaning, English to ASL or from ASL to English. When a person interpreters in clinical service settings, there's an additional concern. Interpreters, because of the nature of their work, understand and convey meaning to ASL or from ASL to English. When a person interpreters in clinical service settings, there's an additional concern. Interpreters, because of the nature of their work, understand and convey meaning to ASL or from ASL to English. When a person interpreters in clinical service settings, there's an additional concern. That is, most interpreters know about dysfluency within the deaf population that originates from social and education reasons. But most have no awareness that dysfluency might have other sources, pathological sources, and in the end, they can obfuscate important diagnostic information. Interpreters, both hearing and deaf, should be educated about these other reasons for dysfluency and should seek additional training on distinguishing one from the other. Not because it is the responsibility of the interpreter to make that diagnosis. This responsibility ultimately still resides with the clinician, but so that the interpreter, who has initial contact with the language, can collaborate with the clinician by providing information about the communication, about the nature of the struggle, so that the clinician themselves can determine this distinction.